Welcome to MPN University.tv Clinical Insights. This discussion is about first choice of therapy for patients diagnosed with a non-MF MPN and is moderated by Dr. Ramon V and co-moderated by Dr. Srdan Verstovsek. Our panel discussants are Dr. Elizabeth Hexner, Dr. Brady Stein, and Dr. Josef Prchal.
Polycythemia vera and essential thrombocythemia are the two more common classic myeloproliferative neoplasms. And these patients, some of them clearly require therapy. They have a burden of disease. They also have symptoms related to splenomegaly. And of course, they're at increased risk for thrombotic rates. However, there's of course several issues related to how to approach this in terms of first line of therapy. So in your experience, Dr. Prchal, so what usually prompts you to start therapy on these patients, and what's your preferred first choice of treatment for patients with polycythemia vera?
I think, as you imply, there are some patients who probably don't need treatment. So I think it's important to evaluate patients, and most of us have put patients with ET and PV, which are very similar disorders, into three different categories: low risk, intermediate risk, and high risk. And then there are also some differences, differences of opinion, what constitutes intermediate risk or not. But I think the consensus is that one of the major determinants is age, but the most important determinant is previous thrombosis and either arterial or venous or transient ischemic attacks. And there is no question that patients who've had any type of thrombotic complication before are at much higher risk of having it again. There's also a lot of evidence that any type of myelosuppressive therapy markedly decreases thrombosis. So one has to clearly balance the benefits and risk of the treatment. And certainly there is a lot of evidence from one of the first trials performed in medicine, Polycythemia Vera trial, that thrombotic complications are markedly reduced by any myelosuppressive therapy. But the previous therapies, which included alkylating agents and radioactive phosphorus, clearly also had the detrimental effect of marked increased risk of leukemia. Although in the original study, the radioactive phosphorus was a little bit superior to phlebotomies, yet it markedly increased risk of leukemia. And so the question is, now we have more than one agent, and there is still some controversy what is the best agent. But I think there are two agents which have been proven to be beneficial, and the question which one is better. And there is those agents, as you know, is hydroxyurea and interferon. And since interferon has a lot of toxicity, I think the Dr. Verstovsek was one of the pioneers, and Dr. Silver and Harriet Gilbert have used interferon very early in this disease. But now with the long-term, all the variants of interferon which are pegylated, which is much better tolerated, the issue is what is the benefit and detriment of hydroxyurea versus pegylated interferon alpha? And I think that it remains to be determined. Yes. We have to await some firm data to find out what are the relative advantages and disadvantages.
Do you ascribe to this also, Brady? How about in your experience, like, what usually prompts you to initiate therapy in these patients, and do you kind of follow the same approach of hydroxyurea versus interferon, or is there any other treatments that you would consider as frontline therapy for these patients?
So first, there's therapies that we'd prescribe for everyone, phlebotomy and aspirin. And then when we think about additional therapies, it's really, right now, largely based on their vascular risk. And I think the vascular risk assessment certainly can improve. I think right now there are consistent variables, but they're somewhat generic. They apply to thrombosis in general rather than PV and ET more specifically. So I do use a vascular risk assessment to make a decision to add something. And if I'm going to add, whether I'm going to add hydroxyurea or interferon is really based on that patient, strongly based on that patient's preferences, also based on age. So for younger patients, I've been using more pegylated interferon. For older patients, I think the tolerability of hydroxyurea is much better. So for an older patient who needed a cytoreductive therapy, I'd use the latter.
It's quite interesting that Dr. Prchal, specifically indicated this intermediate risk, kind of the comorbidities kind of play into the whole factor. I wonder how, within the group, how many of them consider, which risk grouping do they look at? Do they typically look at high versus low risk, or do they also consider that intermediate risk group in stratifying these patients?
So I will categorize someone as high, intermediate, or low risk, though I don't specifically recommend cytoreductive therapy in an intermediate risk patient who otherwise has never had a thrombosis. I think it's kind of an important category just to draw our attention to other modifiable risk factors, and so if they also have a very elevated blood pressure or other more conventional risk factors for things like strokes and heart attacks, we try to be very aggressive about managing those. But beyond that, I don't really know yet what to do with the intermediate risk category. Yeah, that's.
And how about Dr. Prchal with regards to phlebotomy? So, clearly, most people would say, we have to phlebotomize these patients, and in the most recent study, they ascribed this cutoff point of less than 45. Do you think that this is the correct goal, hematocrit, or is there really a different level that we should aim for, whether somebody's a female or a male patient?
Right. I think, as you said, most people would agree with you that the phlebotomy plays a very important part in therapeutic armamentarium of the Polycythemia Vera. I probably represent minority view, and let me just justify why I say that. So clearly in Polycythemia Vera study group, there was an increased risk of strokes immediately after phlebotomy. There is no question about that. There are many other polycythemic states where there is no relationship of hematocrit and any thrombotic episodes. But that doesn't necessarily mean that it's not important for Polycythemia Vera. I think the very influential British study published in Lancet was univariate analysis and was not sufficiently powered to answer that. There is a French much larger studies which did not really show any correlation in more multivariate analysis with phlebotomies. The famous ECLAP study, which used 90 different groups of 1,600 patients, was not prospective, was retrospective, and there was no difference in thrombotic complication between hematocrit 35 and 55. So as you mentioned, I think an important attempt was made to determine the effect of phlebotomy on thrombotic complications, which, as you said, are the major risk of morbidity and mortality, or major determinant of mortality and morbidity. And the study was powered to be much larger than it was. It was very difficult to recruit enough patients because of JAK2 inhibitors and other promising agents. And the data clearly demonstrated that phlebotomized patients had less thrombosis, but it was done on univariate analysis. Again, the patients who did not have phlebotomy had a higher white count, and there is no question that on multivariate analysis, the white count is independent variable of thrombosis. So I think it's possible and maybe even likely that the hematocrit plays a contributory role to thrombosis, but I'm not convinced that it has been yet answered. And the senior author of the New England Journal of Medicine, Dr. Barboy, he's actually evaluating the data on his own. There is no question that phlebotomy also has many detrimental effects. Virtually anybody who's phlebotomized becomes iron deficient. We know the iron deficiency increases the pulmonary hypertension, which we really do not know how common it is. A lot of detrimental effects are mediated by something called hypoxia-inducible factor, and the major inducement of hypoxia-inducible factor is actually iron deficiency. And so there are a lot of prospective data to show that iron deficiency without anemia markedly impairs quality of life. It decreases cognition, increases tiredness, and so I think it is. So I think I've really not been convinced that we know that 45 hematocrit is optimal, and I can elaborate on it more. But I think that there are data about optimal hematocrit in normovolemic patients. But if you do the study of oxygen delivery and many other studies, it's highly determined by the total blood volume. Well, we know in patients with polycythemia vera, the blood volume is markedly increased. So the optimal hematocrit for polycythemia vera is not determined. And there are a lot of data to support this. So again, most physicians and most hematologists feel that phlebotomy is a very important part of therapy of polycythemia vera. Based on data which I think are very weak, it's been recommended that hematocrit 45 is a desirable range, but I'm not convinced. I certainly have much higher hematocrit than that.
Now you mentioned white cell count as a possible another prognostic factor, and this also comes as a factor in some studies in ET.
Right. Absolutely.
Would that factor be ready for everyday use to determine introduction of the cytoreductive therapies?
No, I think that's a very important point. I think that in the retrospective multivariate analysis, the white count plays extremely important correlation between thrombosis and unfavorable effects. And how one clinician takes into consideration to choose the therapy is not clear. I think, as Dr. Hexner indicated, there are some other factors such as diabetes, uncontrolled hypertension, smoking, which probably play an important role and should be taken into consideration. And I think we still have to generate firm data which would help us to use all these individual variants to choice of appropriate therapy.
And there are other factors that are coming up in a number of papers, like allele burden, the JAK2 allele burden in PV. Looks like we are discovering some important factors, but from what I'm sensing from your description, is not ready for a prime time.
Right. No, I fully agree with you. I think there are again data demonstrating, although the not all the papers indicate that, but I think I'm convinced that the aggregate of all published data demonstrate that the higher allelic JAK2 burden is higher risk of thrombosis. How in its strength it correlates with white count is not certain. My sense is the white count is more important determinant.
And actually, there have been some cases, Dr. Prchal, for example, if a patient is already on cytoreductive therapy, let's say interferon, because the patient had a prior thrombotic event.
Yes.
And the white count happens to be like 50,000 or 60,000. Do you titrate the dose of your cytoreductive therapy to achieve a normal white blood cell count, or how do you titrate?
Yeah, no, as you know, the study showed that white cell count is a continuous variable, so which means that white count of 8,000 is worse than 4,000. And I'm convinced that those are correct data. It's interesting that there are other disorders which are congenital, such as sickle cell disease, where the white cell count also plays the same important determinant in vaso-occlusive crisis. And there is also some argument that statins, which are very beneficial for cardiovascular disease, also change the function of white cells. So I strongly think that we have to take into account of high white count, and I feel very uncomfortable when my patient has a high white count, and I try to reduce it as much as I can. And again, I think Dr. Hexner, stated something which most hematologists are very afraid, and that is not to use hydroxyurea in younger people. But again, the children with sickle cell disease have been using the prospective studies hydroxyurea, and I was part of that study, and there has been no increase of leukemia with hydroxyurea. And more importantly, the Swedish study also didn't really show any increased risk of leukemia with hydroxyurea.
One question on use of interferon. So in most recent guidelines for therapy of PV, interferon and hydroxyurea have been leveled at the first place together, one or the other, and we are arguing here, discussing who would be a candidate for one or the other. We all appreciate that the goal of therapy is to decrease the risk of thrombosis. Yet there is a large concern on a patient part about progression of the disease, not just to acute myeloid leukemia, but higher risk is to progress to myelofibrosis. And the results of a molecular response with interferon opens the door for one to argue that we should be treating everybody with interferon.
Right.
You know.
Well, I think there are very enticing basic science data about interferon. One of them is something which my group has been interested in, that in some females where we can measure clonality, this is the only agent which brings normal dormant hematopoietic stem cells to cycle. That's a positive view of interferon. But there are also some other data in mice that the interferon decreases stem cell pool by comparative repopulation study, which may be detrimental. And I think the long-term studies are needed, and some of them are being done, and clearly there are differences in side effects, and there are differences in efficacy, and as I think Dr. Hexner and Stein has mentioned already, the hydroxyurea is much, or you mentioned, hydroxyurea is much easier to tolerate than pegylated interferon alpha, but if you start pegylated interferon alpha with very low dose and gradually increase it, I think that the interferon is tolerated better than if you start with what you think is an optimal dose.
Moving into essential thrombocythemia, Brady, like what's your first approach for patients with essential thrombocythemia?
I think it would be similar to the patient with polycythemia vera. I think we first have to decide who really needs cytoreductive therapy for essential thrombocythemia. And I've seen many patients who are treated based on the platelet count alone. The platelet count has never been correlated with thrombosis. The higher the platelet count, there's a correlation with bleeding. But I've seen many patients who would have never needed therapy but have now been on hydroxyurea for 12 years based on thrombocytosis alone, younger patients. We've also seen many more patients with ET suffer consequences of cytoreductive therapy rather than experience consequences from their disease. So we've got to make sure that the therapy of ET is not worse than the disease. So I think for ET, it's very, very critical that we decide who needs cytoreductive therapy. So the risk stratification, somewhat similar, very similar actually, except for it's evolved a little bit with IPSET, looking at patient-related factors, age, and prior history of thrombosis. The IPSET thrombosis now looks at the mutational profile, so the incorporation of the JAK2 mutation, and cardiovascular risk factors are incorporated as well. So it's a little bit better than what we use for polycythemia vera, looking strictly at age and thrombosis history. And I think things will get even more interesting as we look at the calreticulin gene mutation in our patients with ET, because those patients appear to have a lower thrombotic risk compared to JAK2 positive patients. So I think in ET, there's a number of really interesting variables that we can use to look at and decide who really needs therapy.
And in your practice, Elizabeth, like, do you use the same risk scoring system pretty much?
Yep.
So do you take into account also, do you primarily use just the traditional low, high risk, or do you use the IPSET?
I'd use the IPSET. The other thing that I think IPSET offers in terms of your conversations with patients is an actual estimation of annual events and risks. And so I think that's useful currency in sort of describing why you're recommending something. So that's what I usually use. And I would just echo that I think it's very important to not treat the people who don't.
One other thing that I think is like just a point of, I'm wondering, among the participants, what's the feeling is, it's clearly becoming more apparent that patients with polycythemia vera, similar to MF patients, they are quite symptomatic from their disease. They do have constitutional symptoms as well, and there's a burden of disease. Is it routine in your practice to actually, be able to quantify these symptoms? Do you, routinely collect the MPN symptom assessment form, total symptom score symptoms, or you don't necessarily, how do you, prospectively or continuously collect this data?
I wish that I had a mechanism to do it very easily for everybody. I have my own form that I use really pretty uniquely for patients that I'm with myelofibrosis whom I'm considering using a JAK inhibitor, just because it's helpful in terms of measuring disease over time or symptom burden over time.
How about at MD Anderson, Dr. Verstovsek? Is this something that you routinely collect for your patients?
We collect when the patients see us for the first time. Unfortunately, we don't have a mechanism in place to collect it all the time. But on the other hand, patients participate by and large in clinical studies. And the assessment of the symptoms is usually incorporated, almost always. So that's an important part that you mentioned. But I wonder something else. In ET, we do have anagrelide. Anybody a fan of anagrelide?
I have actually used it for some patients. My first preference is outside of those hydroxyurea interferon. If I have an open clinical trial, I typically go for the clinical trial first. But I have patients who've done extremely well on long-term anagrelide therapy. So I'm not sure what the rest experiences are.
Joe?
Yeah, I've been using anagrelide. I think that, as we all know, there has been very influential prospective 3 trial in United Kingdom, which have randomized all patients with essential thrombocythemia to anagrelide versus hydroxyurea. And the data demonstrated that patients with hydroxyurea had more likely transformation to myelofibrosis. Now, there was a similar study performed in in Austria, and in other European countries, which did not show this. I think the anagrelide has been approved by FDA as an orphan drug because in the trial of patients who had previous thrombosis, there was significant reduction of the rate of thrombosis. And so I think it remains to be answered how valuable anagrelide is. There is no question that some people do well. The side effect profile is different. Virtually everybody gets anemia. The palpitations are subjective. They are not associated with arrhythmia. I think it's a useful drug. But its relative value, I think, would need to be re-examined. And there are now better modalities of using anagrelide than what we used to be before. I think it's used in Europe as a long-term release, which provides more sustained dose and which is better tolerated. And so I think we really don't know enough. I think it's possible that we will be using more anagrelide in future.
The question about anagrelide, though, is if we're not seeing a reduction if we're not seeing a strong correlation between thrombocytosis and thrombosis, the question about specifically lowering the platelet count, what is the true efficacy of anagrelide? If we're wondering about many other factors, the leukocyte count, allelic burden, and other factors.
That's a good point.
Right. But, I've been thinking about the same thing what we all do, but at the same time, the value of platelet count, there is surprisingly inverse correlation of platelet count and thrombosis, has been shown in the retrospective analysis, not in prospective analysis. So we really do not know. I think it would have to be re-examined in prospective fashion, and it may result in different correlation. But I think that's a very important point what you raised.
Now, we all know about the development of a JAK inhibitors as a second-line therapy for PV, where there are not too many options. You can use interferon or hydroxyurea, as we discussed, but there is, it appears to everybody, unmet need for another medication. In ET, we have interferon, hydrea, and we do have anagrelide. We just discussed about it. Is there an area within the ET group of patients where we would say there is a need for another medication, unmet need? What's your feeling about that?
Well, there is a lot of controversy in this area. One of them is an entity of prefibrotic myelofibrosis, right? And I think that a lot of hematologists, including myself, were skeptical about the fact that if this was a real entity, but I think it has been very clearly shown that it does exist. It's much more aggressive form of a disease. The experts who have been trained to differentiate it can recognize it, and it has much worse prognosis. And I think it needs to be studied separately. And as you've all mentioned, I think in the area of calreticulin mutations, I think that all the prospective and relative risk factors need to be re-examined. And in addition, I think we all know that several groups, including my group, have published mutational analysis of germ cells and clonal cells, and virtually everybody with P. vera has additional mutations than JAK2. It's certainly known that the ASXL1, at least in myelofibrosis, is independent variable of very bad prognosis. And I think with increasing knowledge of this, I think it probably will change the way how we handle the disease. But I think it's too early to know what it means for polycythemia vera and essential thrombocythemia.
Yes.
Yeah, so I think we've definitely touched on a lot of very important topics in the management of PV and ET. It's clear, I think, that in as far as determining who are the patients who will benefit from first-line therapy, it is important to use specific risk stratification systems. People have used the IPSET system for ET, and then of course for patients with polycythemia vera, and defining them into a low, high-risk group. But of course, not forgetting the comorbidities that can certainly contribute to the disease is quite important. And interferon and hydroxyurea remains very important therapies. However, in the ET setting, there's also anagrelide that's another treatment option. I'd like to thank all the participants again of this discussion. Thank you.
Thank you.
Thank you for chairing it so well.
Thank you.